Hi, I'm Pat Anderson, editor of MIMS Learning, and I wanted to tell you a little bit about the MIMS Learning subscription. This annual subscription gives you full access to exclusive subscriber content, ranging from clinical reviews to extended learning and recordings of our webinars. So come and check it out. If you take out a subscription, you'll find that it gives you stimulating learning, keeps you up to date on all the hot topics, and helps you with your appraisal process. So have a look today at the MIMS Learning subscription. You'll find it'll really add value to your learning.
Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning, and I'm delighted to be joined by Dr Joy Shacklock, RCGP Safeguarding Lead and a named GP for Child and Adult Safeguarding in North Yorkshire and City of York. Welcome, Joy.
Lovely to be here. Thank you for having me this morning.
My first question to you would be, what do we mean by safeguarding for children?
It's a really broad question, and safeguarding actually is a broad concept and a really broad action. And I think the first thing to say is safeguarding is rarely a one-off event with children. Often it's a process. And as we, particularly in general practice, as we build up pictures over time. So the fundamental principle about safeguarding children is, one, we want to prevent abuse and neglect happening to children. That's what we all want to happen. And then where it is already happening, we want to be able to identify abuse and neglect to stop it from happening further and to stop it escalating. So that's ultimately, it's about keeping children safe. That's what we're ultimately talking about.
For a GP, they have a legal role in safeguarding. So can you talk a little bit more about their professional responsibilities and their legal role in identifying and responding to safeguarding concerns?
Lots of professionals and professional bodies in the UK have legal and statutory responsibilities for safeguarding children, including all of health, teaching staff, police. We are one of a partnership. Safeguarding children is very much partnership working, and GPs in general practice are a key partner in that partnership around children to keep children safe. As GPs, we were all doctors, and therefore we go by our GMC guidance. The GMC are very clear about our duties and responsibilities to keep children safe from abuse and neglect. They updated their good medical practice last year in 2024 and highlighted within that our duties to safeguard children and adults, of course, as well. They have two particular documents, 0 to 18 and protecting children, that all doctors and all GPs should be really aware of, which sets out what our professional responsibilities are in keeping children safe.
Is it the same as the RCGP safeguarding standards for general practice?
They're two slightly different things, but same purpose. So as the Royal College of GPs, we made a decision over a number of years, because safeguarding standards have been around for quite a while, actually, and intercollegiate documents previously, and they still exist. But within the college, we felt that we needed safeguarding standards that were specific to general practice, that took into account our specific role in providing universal healthcare, the particular set of skills and expertise that we have as generalists, I guess. And we wanted to build a set of standards that was applicable to anybody working in general practice, not just GPs, and relevant to our role, and also mindful of the resources that we have or don't have, because we talk about safeguarding being everybody's responsibility, and safeguarding is everybody's responsibility, but sometimes we get a bit lost in that then about, well, who does what and what is our specific role. So what we've tried to do with the standards for GPs in general practice is to really outline what our role is in general practice, what can we do in general practice, and how do we do that well. We're not social workers, we're not police, that they have different roles. We all have the same aim, but it's trying to outline what our role. So I suppose the safeguarding standards from the RCGP build on the kind of top level principles from the GMC around our responsibilities. So they very much complement each other.
And can you just talk a little bit about the core principles of the RCGP safeguarding standards?
Absolutely. So we broke them down into 5 different areas that we thought were the key things that we needed to be able to do in general practice. So the first one is professional responsibilities. So that's just outlining what are, just as we've said, our legal responsibilities, GMC responsibilities, etc. Then identifying abuse and neglect, responding to abuse and neglect, documentations. That's really important for us in general practice, particularly with patient online access, about how we document safeguarding concerns. And then the fifth one is about information sharing and multi-agency working. We made a move to our standards, our whole life course, so they cover both child and adult. Safeguarding standards have historically been separate, and there are separate things, legislation is different, for example, with children than there is with adults. But for us in general practice, there are so many things that are the same. So in terms of how we, for example, how we document safeguarding concerns in the patient record, it doesn't matter whether that's about a child or an adult. The advice is the same about having accurate documentation and hiding it from online access so that we're not putting victims more at risk, for example. And then our toolkit matches those 5 areas as well. So we've set our new toolkit to match those 5 areas to support the learning.
Oh, that's interesting. Can you talk a little bit about this toolkit?
Yeah, absolutely. So with each of these 5 areas, we've then, in the standards, we've broken those down into really quite a lot of detail. So in the documentation section, for example, we have knowledge and competencies around knowing how to document safeguarding concerns. Part 4 of our toolkit is around documentation. So we have a whole guide in our toolkit then to match how. So what does that look like then? So we're asking you to do documentation well, but then we've also produced a guide to help you how to do that. And that includes a list of codes. We've chosen a relatively short list of codes to use that we want to have a shared language really of safeguarding across all of primary care, across the 4 nations, because of course our Royal College guidance is for all 4 UK nations. Everything's slightly different in each UK nation. Coding, SNOMED is not used everywhere, for example. We wanted to encourage a really shared understanding of safeguarding, so that no matter if you are a GP locum, you do the occasional clinical session, you're a GP trainee, when you look at a child or adult's records, you can instantly identify that there has been a safeguarding concern if we're all using the same coding and documentation. So it's trying to help that kind of shared understanding. And also, as we know now in general practice, there are so many different people who work in general practice. So as a patient, you don't always see the same person. You might see a physio one time, you might see GP another time, you might see a practice nurse another time. So it's really important that all of those individuals and professionals that you see in general practice, 1, have the same training and have the same skills, but 2, can look at records and go, okay, this is a child who is more vulnerable. Just for example, this is a child who we know is being sexually exploited. So how are we going to make sure we're proactively supporting this young person and making sure they're okay? And that's kind of one part of our tool. So we've matched the toolkit to the standards. In our identifying abuse, we list all the different types of abuse for both children and adults. We've got a section on domestic abuse, for which we have then developed, looking at how you might look at what different levels of risk are in domestic abuse. So we know that domestic abuse can be really tricky to ask about, can be really tricky to know how to respond to it. And the response often has to be different depending on if it's high risk domestic abuse or whether it's just an emerging picture. So we have built a way of thinking about that, and what does high risk domestic abuse look like, and what are your options in that situation, for example. So post ICSA, so I'm sure many of our listeners will have heard of ICSA, which is the Independent Inquiry into Child Sexual Abuse in Institutions, which is a huge inquiry that ran over a number of years, obviously had thousands of testimonies from survivors, and has really raised the profile of child sexual abuse, and that we all need to be doing better to identify children who are being sexually abused. Children don't walk into a professional and go, oh, well, I'm being sexually abused, by the way. That's not how it happens. And we have to be trained to, and we have training to pick that up, but we worked with the Centre for Expertise on Child Sexual Abuse to develop a resource on talking about child sexual abuse, because we know that's one of the biggest barriers, is people don't know how do you bring it up, how do you talk about it, how do you ask about it, and am I interfering with a police investigation if I ask about it? Or we've built a resource with the Centre for Expertise on Child Sexual Abuse, who have amazing resources, by the way, on child sexual abuse, to help practitioners and break down those barriers, with the key message being really, you have the skills already. As a GP, you have the skills to listen, have empathy, use your professional curiosity, consider risk, look at the bigger picture. You have all those skills already, and you can use those in safeguarding as well.
That actually sounds like a really useful set of tools and framework. So, talking about injury, as you mentioned, it can be a sign of physical abuse. So, what are the red flags that this might be abuse rather than an accident or some other cause?
It's always really tricky, isn't it? So if we think about bruising, for example, bruising, as we know in toddlers, for example, is really common, isn't it? Bruising on shins and heads and that kind of thing. But whenever we are thinking about non-accidental injury, it's context, a lot of it. So bruising in a non-mobile baby, for example, should always raise your concerns, and you should always be considering whether abuse could be at play there, for example. We don't probably necessarily see lots of injuries in general practice, but when we do, it's asking about how did it happen? Does the story fit the injury? Has there been a delayed presentation, for example? So has there been an injury and it's not been presented? And that can be for all sorts of reasons. It doesn't necessarily mean that it's absolutely abuse, but it's those kind of things that you should be thinking of. And I guess any bruising or any injury, and with anything that we see with children really, child abuse always has to be in your differential about when you're going through in your head, what could this be? Child abuse needs to be in there all the time. I guess it, for us in general practice, particularly with older children, we're possibly more likely to see behaviour changes. So be that children becoming angry, children becoming withdrawn, bedwetting. And again, bedwetting is really common, isn't it? In children, it's part of normal development in many ways. But new bedwetting, for example, we instantly have to think about urinary tract infection, for example. We must always be thinking, actually, could there be trauma here in this child's life, and could this bedwetting actually be an indicator of something else? When it comes to injuries, it's about being really aware, particularly with non-mobile babies. So non-mobile babies and any injuries and bruises, your child abuse has to be up there always in terms of that consideration, because we know that that age group, so under ones, for example, unfortunately feature quite heavily in safeguarding reviews where children have died or seriously injured due to abuse, and bruising is one of the things that can come alongside that.
This is a really sensitive issue. So, apart from physical injury, what are some more subtle signs that would be indicative of neglect, sexual abuse, or emotional abuse that GPs need to be on the lookout for?
Yeah, so many different types of abuse, isn't there? And the legislation categorises it into those four areas, so physical abuse, neglect, sexual abuse, and emotional abuse. But we can break that down even further into bullying, cyberbullying, child exploitation, child criminal exploitation, domestic abuse, radicalisation. So the list can go on and on about lots of different risks that our children face. Part of it is also being aware of different life stages of children. So for babies under one, for example, the highest risk is probably within the home. Whereas when we're talking about teenagers, for example, obviously their risks that they face are very different. Online risks, massive, as we always know. And I think that's one of the really important things to think about with children when we're thinking about abuses. Don't forget the online space. If you're thinking about asking about school, home, think about online. Is always ask about what's going on online for a child. We know that there's been an explosion in online facilitated child sexual abuse, for example. We also know about cyberbullying and all of that. So there's lots of different spaces. And I think the key as a GP is not that you have to decide or know what is physical abuse, what is sexual abuse. Sometimes there is some very clear indicators for that. So bruising in non-mobile babies might indicate physical abuse, for example. The presence of genital warts in a 6-year-old, for example, we would be worried about sexual abuse. But a lot of abuse presents in the same way. So it's about recognizing how trauma impacts a child and what that might look like. And it's all those kind of things like change in behaviour, become more withdrawn, mental health issues, self-harming, suicidal thoughts. Abuse should always be considered in those situations. But the other big thing with children is often we identify children at risk through our work with adults. So it's not always through our work with children that we identify the risk. It's often through our work as GPs with adults, with parents, with carers. So that is things like identifying or having a disclosure of domestic abuse, for example, and you know that there's children in the house. Just because you've never seen those children It doesn't mean that you don't act on that. You have to act to protect those children. Or we have individuals who pose a risk to children through their sexual offending behaviour, for example. And if you have that knowledge because you've been told that by an agency such as the police, for example, and you become aware that they are having contact with children, then that is something that you have to raise. So there's lots of ways of identifying children who might be at risk. And I think the other really important thing to say is that you do not have to be sure. It is not your job as a GP or anybody working in general practice to be absolutely sure that abuse is happening before you make any referrals, because rarely anybody is ever sure. And often it's about building up a picture over time, and with other agencies, that's where our information sharing comes in, because sometimes the picture of what's happening in a child's life only becomes apparent when lots of agencies share. So schools share a bit, GPs share a bit, social care have a bit, maybe police have been called out to a domestic abuse event, and putting that picture together. The key principle of child safeguarding is looking at it through the eyes of a child and thinking about what is the lived experience of that child. So when you've got adults where there's domestic abuse, for example, where there is perhaps drug and alcohol addiction, where there's significant mental health, always thinking, what is the impact on the children in that house? What is their experience? Are they safe? How can we support them better? And that's one of the tricky things with children's safeguarding, because particularly for non-verbal children, so babies, and non-verbal children can be children of any age, and also thinking about how children communicate. Children communicate to us by their behaviour. Children rarely will tell a health professional, for example, that something is happening at home. They might do if they're older, but if they're there with their parents, they may not do. But understanding that children communicate their distress in lots of different ways, and behaviour is a key one of that. And I think not expecting children to tell us. I think we obviously want to talk to children and give them opportunities to tell us, but just because a child doesn't says that no, everything's okay at home, but actually we've got all of these other things that we're worried about, we still have to take action to allow social care, for example, to investigate further to see what life is actually like for that child.
That makes sense. And if abuse is suspected, what are the GP's next steps?
So it's good to refer back to the NICE guidance on child maltreatment for this, which has been around for a lot of years, and they talk about consider, suspect, exclude. So they talk about different indicators where you might be considering child abuse. So, for example, that could be in the context of child sexual abuse, for example, if we have a child who's coming in with repeated tummy aches, repeated sore bottom, there can be lots of medical reasons for that, but child abuse and sexual abuse has to be one of the things that you're thinking about. So at that stage, it would sit in your consider level. So you're considering it along with lots of other kind of things. Then say, for example, you examined that child and they had genital warts. Now, it's not something we commonly see in general practice, it's just an example. That would move your concern up to suspect. So whenever you suspect child abuse, the GMC is really clear about that. You must make a child safeguarding referral, child protection referral. Language is slightly different depending on which UK nation you're in. But if you suspect child abuse, you must make a referral. There is no doubt about that at all. When it's in your consider box, you might want to consider bringing the child back, reviewing things. You might want to think about, does this family need some early help? So making an early help referral just to look at more support for the family, particularly if many of our families are under so much pressure, aren't they? So families who live in poverty, families who are homeless or on the brink of homelessness, families who experience racism, those who are asylum seeking families. There's so many families who face so many external pressures. Our goal really with families like that is to support them as much as we can and get them the right support. Not about saying, oh, you're neglecting your child, or, but actually if you're living in poverty, often parents are doing the best that they can. So we want to be making sure they are protected and supported. And then there's the exclude one as well. So you might have an injury that actually the explanation seems very, really fits with that. The child has confirmed that you've no other concerns. I feel that at this point in time, I can exclude abuse, but always keeping your mind open to if that child recurs with the same thing or there's something else happening. And I guess the thing with children is always about context. So whenever we look at a child, so if we've got a child who comes in with change in behaviour, for example, we need to think about mental health, we need to think about neurodiversity, all those sorts of things as well. But we also need to be thinking about what's happening at home. And actually, if we know at home, which sometimes we do as GPs, that we know that actually things are really difficult at home, that one of the parents has an alcohol addiction and one of the parents has significant mental health, what is the impact? It's looking at a child in context of a family, really, and not being afraid to put the child first. I think that's the other thing. Often we can be swayed by parents or carers saying, oh, it's not a big issue. It's, your core principle is what is life like for this child, and taking actions based on the safety of children.
That makes sense. And what advice would you give a GP on getting this balance between confidentiality and information sharing that they would need to do for safeguarding?
It's a really difficult one. Lots of GPs and lots of professionals get kind of tied in knots about it. So part 5 of our toolkit is on information sharing. We spent a very long time, months and months, developing an information sharing guide to try and tackle this issue, because missed opportunities around information sharing is the thing that comes up all the time in reviews of children or adults who have died or been seriously injured by abuse, where abuse and neglect is a factor in that. And missed opportunities around information sharing frequently comes up in that. So we've tried in this guide to break down what that means. We've got 2 things to think about from information sharing point of view. We have 2 different kind of laws to think about. So we've got the common law duty of confidentiality to consider, and then we have data protection law as well. And we often get ourselves tied up in knots around that. But the key principle about all UK law regarding confidentiality and data is that nothing prevents you sharing information when it is about children at risk of abuse and neglect. The laws are there to provide a framework for how necessary, proportionate and relevant information should be shared. But no law is a barrier to information sharing when it comes to safeguarding children. Now, that isn't always easy. So there are some kind of really clear situations where information sharing is easy. So if you have a request, for example, from your social care, their child safeguarding partnership, who ask you to fill in a form for a child protection conference because a child is deemed to be or has already been significantly harmed. That's easy. You fill in that information, you fill in that form, and you share that information. We hold important information. The trickier part can come at a kind of a bit of a lower down stage, where you might have a family member you're starting to be a little bit worried about, or there are a few things going on, or you think, oh, is there something more going on here or not? And the family haven't given their consent, for example, for an early help referral, and you're kind of feeling a little bit lost in that situation, kind of do I, don't I? The common law duty of confidentiality allows you to share information in 3 broad scenarios, really. So 1, where there's patient consent; 2, where there's a legal process, so a court order, for example, that requires you to share information; and the other is in the public interest. So if you are really concerned about a child and really worried that they might be experiencing abuse and neglect, you absolutely can share, and you should, and you must be sharing information. We do worry about breakdowns in relationship with patients from sharing information. We know that there's often a lot of stigma around the referral to social care that we all need to work to break down. But I often say to parents or to carers or to young people or whoever it is I'm talking about, is that actually it's my job as a doctor to think about all of the things that might be causing this particular issue. And it's my job as a doctor to make sure that you are safe, or to make sure that your child is safe. And in this instance, I need some support, and we need to have some other agencies involved to help us do that, and to help make sure that you have the right support. Because that's what we're talking about. We're not talking about making judgments on parenting. We're not talking about making accusations towards anybody. What we are always talking about is the safety of children. And if you are concerned about the safety of children, you absolutely can share information. It's a bit easier with children actually than it is with adults. It gets a bit more complex with adults when we take into consideration mental capacity. It gets a little bit trickier trickier with adults. And the GMC also say in their guidance that if you share information because you've got a suspicion that a child might be being abused, and it turns out they're not, it turns out that, and that's what we hope for, isn't it? It's a bit like every cancer referral we make. We hope that the person doesn't have cancer, but if they do, hopefully we've referred them early enough to have the right treatment and all of that. And the GMC says that doesn't matter if you have referred on the basis that you had suspicions that a child's being abused. Even if it didn't turn out to be abuse, you've still done the right thing. So the law and our professional guidance and standards back us up around that as well. I think the other thing to say is if you were never sure, ask for advice. That's the other kind of golden rule in safeguarding. If you don't know or you are not sure, which we all are at times, talk to somebody. So talk to your organisational safeguarding lead, talk to your safeguarding leads in your area, depending what setup you have and depending where you are. Talk to your Caldecott guardian. For example, there are lots of people that you can talk to. Don't manage things on your own. If you're unsure about it, always talk to somebody.
So there have been numerous cases where there is abuse, but that has been missed because of stretched resources. So what can GPs do to ensure that children are not falling through these gaps because of the stretched resources?
It's so difficult, isn't it? Because we know all services are stretched, don't we? We know that health, we know that social care, police, education, any kind of publicly kind of financed service is hugely under-resourced, and it is really difficult. And we know that GPs feel that frustration as well about not having the time that we would really like to have with our patients, or not being able to see them as frequently as possible. And I think, and what we've tried to do with the standards is really recognise that, and therefore sort of recognise what it is that we do well in general practice and safeguarding. And that comes to, I would pull us back to those kind of 5 key areas. So in terms of understanding your professional responsibility, so understand that you have a duty and you have a responsibility to act when there are concerns about abuse, about children and adults as well. So understanding that kind of first and foremost. Educating yourself then on identifying what child abuse looks like, how might that present it in general practice, then knowing what your local processes and pathways are to manage that. Documentation is so important because that gives us a building of a picture over time, and then understanding your responsibilities around information sharing are really crucial so that you can be confident in sharing information when you need to. And when it's about the safety of children, there is generally always a need for that. So it's around those 5 things. One of the things that has changed with the standards is what safeguarding training is required now. Going forward, it used to be hours based, so it used to have to do a certain number of hours based training, whereas now it's an annual update every year. And for level 3 staff, which is all clinical staff effectively, they also have to demonstrate how they've embedded their learning. So we want to move, safeguarding training had become a bit of a tick box exercise to be done every 3 years, and we've moved completely away from that to actually how you embedding your learning into your day-to-day practice. So for those listening to this podcast today, what are you going to do next? What is your kind of next steps? How are you going to make a change in your practice? And that might be, actually I'm going to go and have a look at the toolkit, or actually I don't know my responsibilities around information sharing. I'd like to know more about that. Going and reading that, and then how you put that into practice. So we're moving very much for safeguarding training and learning to be embedded in your day-to-day practice, not just I've done that for my appraisal, I don't have to do it again. It's about making a difference to child and adults. That's the best that you can do, if that makes it. Despite all the resource implications, we know that we're vastly under-resourced, but if you do all of those things, you are doing the best that you can for children.
That's really useful. Thank you. And what are your key take-home messages for GPs about safeguarding children?
Don't be afraid of it. I think it's probably the first thing. Don't be afraid to talk about it. Don't be afraid to ask about it. Get used to doing it. That's the first barrier. A lot of professionals feel, I don't want to, I know this family really well and I don't want to accuse them of doing something. You're not accusing anybody of doing so. If you've identified that a child is struggling, if you've identified multiple signs that a child might be experiencing trauma, what you are doing is in that child's best interest. Everybody develops their own way of how they talk about it and how they ask about it. So do that. Use that for any GP trainees who are maybe listening. Practice with a colleague, practice with your trainer, do a mini role play. I know people, I don't want to do a role play, but it's a really really good way of thinking about, how would I ask about domestic abuse? What words would I use? How would I ask? And how would I change that language if I was talking to a 15-year-old? Or how would I make sure that if I was with someone who didn't speak English and I was using an interpreter, how would I make sure that my language is really, really clear when I'm asking about it? How do I ask about safety? All of those sort of things. So don't be afraid of it is the first thing I would say. You're doing this for children, and one of the things that we know as GPs, because we look after people lifelong, is we have so many adults that we see whose lives have been devastated and massively impacted by childhood abuse, don't we? We see that side of things. So remember why you're doing it. You were trying to stop something awful happening to a child and making their life chances significantly better. That's what we want to be doing. And be an advocate and be a voice for that child. That's the other really important thing. Thinking about safeguarding on a daily basis in all your consultations, always be thinking, could this be abuse? And that doesn't mean that if you're duty doctor one day and you've got 30 patients and they're all coming in with tonsillitis, that you launch into asking them all about abuse. That's not what we're saying. It's about, if you don't think about it, you're not going to ask about it. And I think like domestic abuse, for example, are so common, and domestic abuse can pretty much present with anything. So that if anybody presented with any mental health difficulty, drug and alcohol issue, for example, should be asked about domestic abuse. You should be asking about it into your routine kind of conversations with patients, and think about it as a conversation rather than a tick box exercise. And lots of victims of abuse, and teenagers with this as well, and children and everybody of all ages, may not say anything the first time they're asked, but actually if they know that there are trusted people that they can say something to, and one of the things that I often say to children where I'm concerned about them, I know that a 7-year-old is very unlikely to be able to make an appointment to come back and see me themselves on their own, or that I'm not going to be the professional that they come to. So one of the things that I say to children, particularly school-age children, think about who can you talk to if you're worried about something, or that you want to talk about something, thinking about their trusted adults, giving them options. So, you can give them Childline, but you can also talk about who's your trusted person at school. That you can talk to who's your trusted adult in your family, that if you're worried about something or something's happening to you, that you're frightened, who can you talk to? So it's not just about them talking to us, it's about making sure they have options when they leave our room, that they have options to talk to people. So yeah, don't be afraid, ask about it, embed it into your everyday practice, and follow the kind of five key areas of safeguarding as the standards, and build up. We see safeguarding knowledge and learning as a career-long journey. Everybody's at a different point, and what you're doing is building it up all the time. But just like you build up your knowledge about cancer all the time, or our knowledge changes doesn't around asthma, or whatever it is, abuse is the same.
I'm sure a lot of GPs will find this really valuable. So thank you so much once again for joining me, Joy. Don't forget that you can claim CVD credits for listening to this podcast. You need to just get on our website for that. I've been Sangeeta Krishnan. My guest today was Dr. Joy Shacklock, and this episode was produced by Jude Owen. You've been listening to the Clinical Update podcast. Do tune in next week for a studio discussion with the MIMS Learning editors. See you next time.